Now we're going to talk today about one of the important topics that we're always challenging with it. It's a very common thing. It's changing in sleeping as we age. This is the area of my interest, actually, because we see a lot of patients everywhere, in an office, in a hospital, in basically subacute cares. And the sleeping problem is like a big issue. And it's actually a big market for even the pharmaceutical companies to producing a lot of the sleeping pills. And that's the area that we talk about it. I'm teaching and practicing medicine and geriatric medicine in Stanford. And today, our learning objective is going to be first, we're going to understand what is the physiology of sleep. And that's going to help us a lot to understand that when we sleep, what's going to happen in our brain. And again, then we're going to talk about the sleep impairment and the causes of a sleep impairment. And then we're going to talk about now when we're aging, minute by minute, hour by hour here, what's going to happen to our body to actually have some effects on sleeping. And then at the end, we're going to talk about what's the option of the treatment that we have and what's the approach about sleep. The first thing is actually sleep. It's unconscious, basically, part of the brain. But we can be awake by sensory. And that's a different when we actually talk about coma. When a patient actually goes to coma, it's kind of like a sleep. Or when we go to operation and anesthesiologists give us some medication, actually they put us in a sleep. But at that time, we're not able to wake up with external, basically, a stimulation. But that's a different than sleep. When we sleep, we can wake up easily. And sleep, basically, is kind of like naturally things happen in our body that we don't have a consciousness about our environment. But it's kind of like a sensory activity, kind of like not working. It's not 100%. But again, it's kind of like inactivity of voluntary muscles. And that's very important because involuntary muscles is actually working. Our GI system is still working, or breathing is still working, and this is kind of like involuntary muscles that happen in sleep. But still, sleep is a mystery. I'm telling you, it's in the last 50 years, which the modern sleep medicine is actually more established. We have American Society of Sleep Medicine, and there's a lot of talk and everything. It's very, very challenging. Again, the mystery of sleep is unknown. 1/3 of all of our lives is actually in sleep. And if you have a calculation, we sleep 8 hours a day. I hope that all we sleep 8 hours a day. It's never happened to me, actually. But 56 hours a week, 224 hours a month, and 2,688 hours per year. That's the amount of basically the hours that we spend on sleeping. And basically 1/3 of our life is actually in sleep. That's very important, like 1/3 of all of our life in sleep, but still we have a lot of problems. And we go quickly to physiology. We have two phases for sleep that we call a slow wave sleep, and we call the other phase is rapid eye movement sleep. And during basically every night, a person goes to the two stages of that. The one is a slow wave sleep that is basically the brain waves are strong, but has a low frequency. This is the first phase of sleep. And then we go to rapid eye movement phase, which the eyes goes on the rapid eye movement, but still we are sleeping, but not as deep as we are in basically a slow sleep. This is the picture of Dr. Dement. He is actually one of the retired professor of sleep medicine. He's the father of the modern sleep, and he's actually one of the faculty of Stanford. And he actually was the person actually found the REM sleep. And when we go to the slow wave sleep, again, we talk about it, is deep, restful sleep that we always have it. Imagine that you have a long days, many hours working, exhausted. This is the first phase of your sleep. And that's we call a slow wave sleep. And then when we go to the REM sleep again that we talk about it, 25% of the sleeping time is that time. It's happen every 90 minutes, like we go 1.5 hours to deep sleep. Again, after that, we're going to have a phase of the REM sleep. And 25% of total of our 8 hours of sleep going to be in the REM sleep. And this is the time, the REM sleep, that we're going to talk more in detail. This is the time that all the dreaming is going to come. I mean, we have a dreaming and all the things is going to happen in this phase. In this picture, which I got it from a Stanford library, this is very nice. This is a stage 1 from the top. We're talking from here that we have light sleep at that time that actually, this is the first hours of our sleep. When we go to bed, ready to sleep, stage 1 is going to happen. Or still sleep is very light in a stage 1. The eyes move very slowly. The muscle activity has started to become down slowly. And again, the people able to basically awaken in stage 1. And again, we sometimes remember what happened in stage 1. This is like, imagine if you go to bed at like 10 p.m. This is the first thing that's going to happen around the 10:15, 10:30. This is a stage 1. And when we go to a stage 2, which is actually, it's a longer basically period, or eye movement is start to stop, and or brain wave becomes more slow. And this is the time, if we do the electroencephalogram, we can actually see the spindle of the spine. This is the deepest sleep. Most of the dream that we have in this stage, we can't remember. It's very deep. And then we go to basically a stage 3, which is a deep sleep. This is the very short period of time, but we have a wave that we call delta wave. And then this is the time, and with the stage 4 that we're going to talk about it, that we don't have any eye movement, and the brain activity kind of like becomes slow. This is the time a lot of the problem, like for example, the kids, they're going to have urination in the bed. This has happened in the deepest sleep. They don't know what's going on. Very deep, quickly goes there. A lot of people, they're going to have a nightmare, very bad nightmare, night terror. They can have a sleepwalking as well. This has happened in the deep phase of a slow wave. And then we're moving from this slow wave to the REM sleep, you see on the left side, which the breathing becomes more irregular. And at that time, the eye movement start to jerk and rapidly, basically in a different direction. We're going to have a limb muscles start to become paralyzed, heart rate start to increase, blood pressure is kind of like rises. And we actually see that if we awake from the REM sleep, we actually describe some sort of, oh, I had a bad dream last night. This is the REM sleep. This is the phase. If I wake you up in a stage 2 and a stage 3 and 4, you don't remember what happened. But if I wake you up in a REM sleep, you actually say, wow, that was a very bad nightmare last night. And that's the REM sleep. And we're going to talk what's going on in each phase. Again, the stage 1 that we talk about it, transitional period from light to sleep, and then this is the time we go fall asleep. And again, this basically is sleep. It's referred to, we feel drowsy, somnolence, and again, muscle tones is going to kind of lose, and we have some consciousness about basically our environment. Still, if the phone is ringing or something is happening, this is the first hours of our sleep. And then we go to a stage 2 that, again, we talk about it. It's kind of like a very, very decrease of the sensory. We have the consciousness and awareness, basically awareness of external stimulation is actually disappear on a stage 2. I wish everybody is sleeping only stage 2, but it's hard to be in this sleep. But the stage 3 is, again, we talk about stage 3 and 4, which is very deep sleep, delta wave. We can have a night terrors. We can have the nocturnal, basically, urination, especially in the kids, and sleepwalking is actually happening that. You will see here on the bottom, from 10 p.m., it started from 0, and then go to a stage 1, 2, 3, 4. You see comes all the way to the end, and 11 p.m. And 11 p.m., you actually back again around 11 p.m. to 12 a.m. to the REM sleep again. And you will see, when you go from 12 a.m. toward the 1 a.m., you have less deep sleep. You're already done with your deep sleep. You actually go again in stage 1, 2, 3, less 4, and then you go back every 90 minutes to REM sleep. That's the cycles all the way go toward the morning. Toward the morning, you have more REM sleep. That's one of the reasons that we remember most of the dreams we have in the morning, like 4 o'clock to 6 o'clock in the morning, not the dream that we have around 12 or like 2. And this is, again, the same thing. You started from midnight. You're still awake. You go stage 1, 2, 3, 4, and the red one is actually REM sleep. And you see this cycle is going to start till 6:30 in the morning, and this is the time that we're going to wake up. And we all remember a slow wave sleep. This is, again, the sample of that. Imagine that you are not sleeping for 24 hours. You're in travel. You're working at nighttime, shifting, have a bad time. And you will see when you go to bed, what's going to happen. The sleep that you're going to have after 24 hours is really restful. I mean, you basically jump to the bed, and that's it. You sleep so deep. This is the stage 1. Means your brain is only getting a slow wave. And again, decrease in both peripheral vascular tone. A lot of the vegetational functional body is actually going to decrease. You will see 10 to 30% decrease in blood pressure, respiratory rate, and basic metabolic rate when it's happened to a slow, basically, a slow wave sleep. But when we go to the REM sleep, which is paradoxical sleep, again, we talk about in a normal night of sleep around 5 minutes to half an hour, like 30 minutes. And every 90 minutes, this phase is going to start. Again, when the person is extremely sleepy, each phase of the REM sleep is short and maybe absent. But if we are very rested, the duration is actually going to be increased. And that's the difference. If we are very tired, we have less REM sleep. If we have a good day, getting a couple naps during the day, when we go to bed, we have more REM sleep. And that's the difference between that. And we will see today that how is actually going to be affected or basically a sleeping phase. And when we talk about the REM sleep, this is again an active form of sleep. We have dreaming, we have active body muscle movement. This is very important. We need to have active body muscle movement in our body. Imagine that we sleep and we don't move. I mean, just imagine that if you go to bed tonight and if somebody put the camera for you and see you tonight in the bed, you know how many times we move? We move a lot. We move actually a lot. And that's the way that actually our muscles not get paralyzed. Because imagine if you're not moving for like 6 or 8 hours at all, then the next morning, we're not able to get out of bed because all of the muscles is actually just paralyzed. But that's the way, and that's actually beauty of creation, that actually we have different phase. We go from slow wave to REM sleep to actually our muscles start to move. And this is good, and this has also some effect that we're going to talk about it. People usually awake spontaneously in the morning. This is exactly the REM sleep. We see a lot. Like if we go to bed, we see most of the time we wake up for any reason. Is it urination? Is it something happened? But when we wake up at the REM sleep. And actually, it's kind of like a sleep becomes light, and then we wake up. Maybe we just open our eyes, again go to bed, again back to sleep. Or maybe we wake up, go to the bathroom for urination. Maybe we're thirsty. We're going to go drink something, again back to the bed. But everything's happened. This is the REM. Means the wave of the brain goes to the REM. You're ready to basically awakening and get up from the bed. And again, muscle tone is depressed, and this is very important. And then we talk about it, why this is important, that our muscles needs to move, but on the other side needs to be kind of like paralyzed, that not moving so fast. Do you know why? Because imagine that we have dream. Like imagine tonight you go to bed and you have REM sleep. And you're going to kind of like moving in the bed, okay? But imagine that you have a dream, like for example, a dog is actually following you. And if you, because your brain is active, if your muscles not getting paralyzed, you're going to acting out all of your dreams. And that's very scary, because then you're going to have a fall and you're not able to sleep. Again, you're not going to acting out your dreams every night. And this is the beauty of that kind of your muscles become paralyzed. And again, this is the center in our brain that actually is specifically working and is responsible to give you some sort of atonia, means your muscles not able to basically contract. And that's why if you have a dream, you're not going to have, again, acting out your dream. And that's very interesting. And again, there are a lot of people, they have something we call REM sleep behavior disorder. And the problem is they by the time or by any other reason, like a lot of people when they get dementia, a lot of people when they get Parkinson's disease, this center in the brain is not working very well. And they are starting to, in the REM sleep, they're starting to fight. They're starting to punching the partner. And it's one of the reasons. And sometimes they're actually acting out the dreams. They may actually get out of bed quickly, go to the bathroom because they want to run away. Something's happened in the dream and they have a fall. Actually, yesterday, before I came, we had a case presentation. I had it with my residency, internal medicine residency, that we had a case with the REM sleep behavior that the guy had it for 3 years, and it was related to one of the medication that we're going to talk about. That medication makes it worse, and the guy had the REM sleep, and he actually get out of bed, walking to the bathroom, fall, and hip the fracture. I mean, and then it's ended up in nursing home. And then that's kind of things that comes with the REM sleep behavior disorder. And unfortunately, again, this is the pattern that we see by aging is happen more, but not in everybody. But this is the REM sleep behavior. And yes, the brain is active during the REM sleep. Means a lot of time, it's very interesting that you can see a lot of memories that you don't remember during your awakening time, like when you are awake, you don't remember a lot of the memories from your childhood. But when you go to sleep, you remember all the dreams very well. And it's kind of like real for you. And you're just, I mean, you're surprised why these dreams came out. After like 60 years or like after like 50 years and 20 years, what is happening that a layer that has this memory, it becomes active during your basically sleep phase. Because the other function of your brain is calmed down, and you're starting to basically, because your brain is active, a lot of these files going to open in your brain. And then actually they did a PET scan, and they compared the PET scan when we are not sleeping, I mean, when we are in the REM sleep and we are basically in a slow wave and non-REM sleep. And you see how much red basically a spot in the brain. Means it's just telling me the brain is very active during the REM sleep. That's why one of the reasons that we actually dream. And again, if you do the EEG at that time, you see the similar basically wave when we are awake. And this is we call paradoxical sleep. We are asleep, but our brain is active. And that's why they call REM sleep paradoxical sleep. Means our brain is still active and is working. There is some theories that actually says why we go to sleep. I mean, why we need a sleep. I mean, why we actually need to have 1/3 of our life. Just imagine, I mean, instead of asleep, we can be awake, we still can eat, we still can basically active. But a lot of the theory is actually coming up. There is a center in the brain that they call reticular system, that we have the picture now. They think that about this centers become fatigued during the basically awake, I mean, when we are awake. And that's when we actually becomes, this centers becomes very basically tired. That's why this is the time we go to sleep. The other things that they have inhibitory basically theory, which is inhibitory process. In this one, they actually found if in the mid-level of the midpoints, like from here, if somebody comes and cut my brain in this basically phase, and you see that the higher level of my brain, it never goes to sleep. But the lower part of my brain, it goes to sleep. Means there is a center in the brain that actually becomes tired, and that's why the whole brain goes to sleep. And that's very interesting, because they've done this test in in animal, and they see this part of the brain never goes to sleep, even when we actually cut it. And there is a possible, I mean, there's a lot of theories coming why we actually sleep. They actually had a model that actually they had some rats. They actually make them awake for like 1 week, and they become so exhausted. They actually drown the blood, they collected the urine, and they inject the blood and urine to another animal, to the brain. And they see that actually this animal goes right away to sleep. Means when we don't sleep, we're producing a lot of things in our body. It's like a toxic metabolic in our body. That's the way that actually our brain goes to sleep. But again, it's a lot of things on details behind it. If I wanted to talk to you one day about physiology, it's going to be, we can talk like days that actually about the details about it. Again, talk about the reticular formation. This is amazing part of our brain. Has more than 100 network in this part of the brain. And this is the part that actually has a lot of things. Tone, balance, posture, during the body movement, has a lot of actually activity. It gets a lot of signal from ears. It gets a lot of signals from the eyes. It's kind of like helping us for more basically coordination. It actually helping us with the gaze, and that's very important. And again, and this is also giving the signals to the swallowing and also the breathing muscles. And this is amazing network. It has some effect on the cardiovascular control, has some effect on the pain, and that's very interesting because this part of the brain goes with the sleep. Then we're going to talk about it now. And then at the last part, this part of the brain is actually responsible for sleep and consciousness, and is a central role basically that we're going to be alert, we're going to be asleep, and it actually shows if we go to like animal or human and we directly go injury the reticular formation part of the brain, we actually all of us, we go to coma, means we go to sleep. Then this part of the brain is responsible for us to be awakened, to basically wake up in the next morning. And this is very interesting because the brain got a lesson that, for example, when a lot of sensory things coming to the brain kind of doing like selective things, because this is what we call habituation. And this is things that, for example, if we living in a crowded place, like a lot of traffic outside, our brain understand that I'm not getting any sensation from the traffic outside, I can sleep, but if I have a child next door and the child starts to cry, I should wake up and then go. Or if my alarm is actually kind of like ringing, I need to wake up and then go. And this is amazing physiology. But for any noise from outside, ambulances back moving, I mean, early morning, something's happening in the street, your brain doing some selective things by the time. And this is very interesting, basically, physiology about the thing. We're producing a lot of neurotransmitter in our brain. And this is one of the things, reticular activating system, producing a lot of the basically hormones or neurotransmitter, we call it neurotransmitter, that they are responsible for us to go to sleep and be awakening. And one of them is acetylcholine. And that's very important. Acetylcholine goes to the nerves we call cholinergic nerves. It's very detailed in physiology. The only reason I wanted to tell you, because it stimulates our brain. And again, why a slow wave is broken periodically by REM sleep, we really don't understand. But the only things we know that if we give to somebody the drugs that mimic the acetylcholine function, that's the reason the people actually goes from slow wave to REM sleep, or they have more dreams. Then one of your answer is why we're dreaming. They think about releasing of acetylcholine from our brain is responsible. And this is very important because a lot of medication that we are taking has cholinergic side effects. And that's we're going to talk in the next basically things that a lot of medication we're taking working on this basically neurotransmitter, acting as this transmitter. Like one of the medication I just give you a sample, it's the medication we give to the people who has dementia. A lot of this medication has cholinergic side effect. And one of the first symptoms that we see in the demented people, they have vivid dreams. And then why they have more dreams? Because I give something to them to help with the memory. But on the other side, the side effect is increasing acetylcholine in there. Cholinergic side effect make them to have more REM sleep. And that's why they have more dreams. And that's very amazing physiology. And then when we go to another one is dopamine. It's coming from basically the part of the we call substantia nigra. And this is basically very interesting part of our brain. Thinking, planning, imagining, a lot of capabilities, intellectual capabilities comes to it, basically dopamine. And when we actually give somebody Ritalin, I'm sure that you hear about Ritalin, that we give a lot of the kids Ritalin. Or we give some people that they are very sleepy, we give Ritalin to be active. Or we drink coffee. I mean, I can't function in the morning without my coffee. I mean, and why I need coffee, because again, coffee is working as like dopamine agonist, like working as dopamine neurotransmitter. And the other one is amphetamine. I mean, a lot of people actually methamphetamine, crystal, they use it, and they make them awake. But why is make them awake? Because again, working on dopamine basically a receptor. I mean, the acting things is enhancing the release and inhibition of dopamine reuptake. And this is turned to basically we're going to be alert and awakeful. We see a lot of teenagers in this stage, they're using methamphetamine, Ritalin, and kind of this medication. Why? Because they wanted to study, they don't want it to sleep. And that's why we can do that. But the other one is histamine. Histamine is also another one. Histamine is actually, if we block the histamine, we go to sleep. Do you remember any medication that is antihistamine side effect? A lot. All of us, we had it. All the cold medication that we're taking has antihistamine. I mean, diphenhydramine, Tylenol PM, and if you go actually to basically Benadryl. Benadryl is a famous one. We actually use Benadryl because we're itchy, but we see, wow, when we take Benadryl, we can go to sleep. Adorex, hydroxyzine, this is all histamine blocker. And the histamine is actually, if you have histamine, you're going to be awake. If you block your histamine receptor in your brain, you're going to go to sleep. And again, destruction of histamine or inhibition of histamine basically has the effect on sleeping. And again, shows a lot of study that histaminergic cells, which is producing the histamine, have most basically wakefulness-related firing pattern of any neuronal type as far as recorded. And a lot of medication that the doctor is giving to you, like me, I always giving to you because I will check and say, okay, if you can't sleep, I will look at it and say this medication has antihistamine side effect. That's the way that a lot of medications make you to sleep. And histamine, again, can be recorded. Firing just broken an animal shows signal of basically awakening, and this goes with the histamine. Again, the physiology function of sleep is still not known. We still know that sleep is part of the important part of our life. Even the mild sleep restriction for a days, we're going to have the problem with cognition, with performance, with productivity, with the health. It's a lot of theory about that. They think sleep is help us to have a better immune system. If we sleep better, our immune system has more ability to kind of like rearrange and go and fight with infection that we have. I mean, we see in ourselves, if for a couple of days we can't sleep, we see that we get easily like a cold. And that's one of the things. I mean, we can see when we actually traveling or like overseas, we get more cold. One of the reasons is germs. One of the other reasons because we're not sleeping very well. I mean, that's something that we definitely know. Sleep has effect on immune system. Again, cognition and memory. I mean, imagine that you're not sleeping for 48 hours. What's going to happen after 72 hours? You're not able to read. You're not able to concentrate. You're not able to do an exam or just doing something very detailed. Definitely, sleep has effect on that. And there was a lot of study actually shows in animals and rats, they make them awake for 2 to 3 weeks, and they say that they actually die. And that's one thing that we can see. If you don't sleep, definitely has some impact in your body. But again, with all the information, we still really don't know why 1/3 of our lives needs to be in a sleep phase. We know that, again, the maturation of the nervous system needs to sleep. One of the reasons that the newborn and babies and infants sleep a lot, they think that because they are generating or basically maturation their nervous system. And that's why you give them the milk, they go to sleep. And you're always jealous, oh my God, they actually go to sleep right away. But this is the physiology of their body, that they are basically trying to have maturation of nervous system. That's the way they're starting to walk, that's the way they're starting to talk. And again, it's helping for learning and memory. Again, cognition, we talk about it. And again, metabolic of energy is another one. One of the very interesting things that I like to talk about it today, and we're going to talk about the treatment, is light. Effects of the light in our sleeping. We have something that we call circadian rhythm, which it's happened for all of us. We're going to talk briefly about that. And again, circadian rhythm that we know that in the morning we have to wake up. We know when the weather becomes dark, we need to go to bed and we need to go to sleep. And this is a circadian rhythm. 24 hours in our body is actually moving. And this is one of the things that is going to be impacted by basically aging. There is a place in basically the suprachiasmatic nuclei, which in our brain is close to hypothalamus area of the brain. This is the place that get the light from outside. Like now, we know this is afternoon. This is not the time to actually go to bed and sleep, unless if you just listen to my presentation and you can go to sleep. But this is the way that actually we know, and we get the light, goes to our retina in our eye, and then the transmitter of the signal goes to our brain. And our brain in the hypothalamus area, this is the place in the center. They say, oh, this is light. This is bright. This is not the time to sleep. This is the time to do activity. But when we see that actually this circadian is actually in 24 hours, it just comes and goes. And when the things that the light enters the retina, we have the supranucleus becomes active. But one of the very interesting things that there is something producing from supranuclear in hypothalamus that all of us, I'm sure that you hear about, is melatonin. We hear all about melatonin, and now there's a medication, melatonin, over the counter, and we actually, a lot of the prescription. And this is exactly things that is producing by this part of the brain. And melatonin is actually a very important part of our body temperature that we're going to talk now, and our circadian rhythm. Again, there's the pineal part of gland in brain is starting to have diffusely producing melatonin, goes to the bloodstream. And again, the synthesis and the relief of this is stimulated by darkness. When it's dark, melatonin is going to be more. And when it's going to be light, the melatonin is going to stop. Okay, now we're going to talk what does it mean. And again, this is very important things because melatonin secretion and core body temperature inversely working together. How is that? Look at here. Here I have 12 basically here, 12, 14, and 20. This is afternoon. You see that in the afternoon, the light is still high, okay? My pineal actually gland, it started from 20, like from 8 p.m. tonight, it started to production of melatonin. And again, in the middle of the night, my melatonin actually goes to the peak. And then all the way, it's still dark, 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 7 o'clock in the morning, there's some lights coming from basically curtain on the window, and my brain understands that, oh, melatonin is coming because, again, light comes to my retina, goes to my brain, and the production of melatonin is going to stop. And that's very amazing physiology. If you look at it, again, if we put the basically light, like for example, if putting somebody in the dark room and we just have a fluorescence light here, and we have between 200 and 400 lux basically, which is indoor fluorescent light, and we see that inhibition of melatonin production is going to happen maximum between 600 after 60 minutes. And this is very important because melatonin level rise shortly after dark and peak around 2 o'clock in the morning and 4 a.m. that we have it in the last picture. And maximum, again, decrease at night, and that the rise in the melatonin 60 to 90 minutes earlier than in the younger adult. Then we're going to talk, there is some change in basically the melatonin secretion as we get older. And in the normal adults, again, but we also talk about melatonin has a relationship with the body temperature. Around the body temperatures, the minimum of the body temperature happen 1 to 2 hours before we actually wake. You can see in yourself, in your partner, or somebody actually close to you, you see that the body becomes so cold. A lot of time when we go to the bed, we don't need blanket right away. But you will see like in like 3 or 4 o'clock in the morning, we actually feeling cold, and we looking for blanket. This is exactly things. Or melatonin secretion has basically adverse and inversely with the secretion, with the core body temperature. And this is the basically happen in the circulation of melatonin, and also or body temperature is actually going to go down. And again, this is a very true component that is very, I love this picture. This is very interesting. Then look at here. We're talking about, we're starting from 6 p.m. We're starting from here. From 6 p.m. we're starting here. Okay, 6 p.m., this is the time that we have a highest body temperature and the highest blood pressure. If you're checking your blood pressure, that's going to be the highest time of the day that you have a high blood pressure. And why is that? Again, vasoconstriction of our body circulation, that could be one of the reasons. And the other things, we have a high body temperature. I'm sure that you have this experience. A lot of us, we feel like feverish in the evening. We feel our body is kind of like more warm. If I get cold today, I see that my fever started evening. And why is the reason? Because my body temperature automatically going to go up in the evening. And I also have a virus infection. That's the reason that a lot of people actually feel fever at the evening time. And that's something that has happened between 1800 to 1900. And again, the dark is going to come. We are moving from 1900, like at 7 p.m. now. We are going to around 9 p.m. The 9 p.m., the weather is dark. I mean, we are here. We're not in Alaska. We are in California, and the weather is going to be dark, and then basically melatonin secretion is going to start, or bowel movement is going to suppress. And that's interesting. I mean, a lot of us, we don't have bowel movement toward the night. The bowel movement is starting in the morning. And that's something very interesting because that's the way our brain is actually acting, that if we're supposed to have a bowel movement every night, that's going to change our sleep pattern. That's why it's actually stopped our cholinergic nerves or intestine not going to moving to have a bowel movement. And again, around the midnight, we are in deepest sleep, 2 a.m., deepest sleep, goes all the way to the 4:30 in the morning. That's the time that we have a peak of melatonin, but our body temperature is going to be in the lowest part. And that's exactly the 4:30 in the morning, we're always feeling cold. And we kind of, if we actually have a camera for ourselves, we see sometimes we're doing like this. And this is exactly 4:30 in the morning because we feel cold at that time. 6 o'clock in the morning, the light is going to start. And again, 6:40 a.m., this is the sharpest rise in the blood pressure. If I have like my blood pressure is always like 120/80, if it's going to be suddenly it's going to go up, it's going to be in the 6 o'clock in the morning, 6:40 a.m. to 7 a.m. This is very important. If my blood pressure not supposed to rise in the morning, what's going to happen? I'm not able to get out of bed. Because in order to actively contract my muscles and get out of bed, I need blood pressure. If my blood pressure is supposed to be like 60/40 at midnight, and in the morning going to be 60/40, I can't move. I'm going to be very lightheaded, very dizzy, and I can't move at all. That means my body and brain says the blood pressure, you need to go up. And it's going to be sharpest rise in the blood pressure. And then we go again, melatonin secretion is going to start around 7:30 in the morning. This is the time. A lot of us, when we wake up, we still kind of feel sleepy because it's still there is some melatonin. Melatonin is going to go down. And again, the bowel movement start to move. And that's exactly in the morning. Again, the people have a different, basically, pattern. And you can see actually in the picture, we have a high alertness around 10 a.m. That's the reason that a lot of, when we were kids in the schools and everything, they always take the exam at 10 a.m. because you're so alert at that time. And that's the way your brain is so alert, you understand what's going on. But the best coordination actually happened around the 4:14, after in the early afternoon. If you really wanted to have a meeting or something for your work or things, early afternoon is the best time that you can actually do it. And again, then in the afternoon, you're so sharp. You're going to have a fastest reaction time. You don't have a fastest reaction time. If earthquake's going to happen, it's better to happen in the afternoon because everybody can be basically have a better reaction to it. And again, the muscle strength. That's one of the reasons a lot of people say it's the best time for exercise is afternoon. You see basically the best time for cardiovascular efficiency and the muscle strength is here, between 3 p.m. till 5 p.m. This is the best time. Early morning is still, a lot of people are debating on that. It's not a good time for exercise because it's still your body is kind of like sleeping. You're not awake. But you can change your body habitus by the time. But this is the 24 hours, everybody's life, me and you, and everybody is actually walking outside. This is the way that we actually living. And who actually has the risk for sleeping? I need to wrap it up because, otherwise we're going to sit until night and talk about sleep. We're going to go to sleep. Again, older adult, women, medical things, and psych issue and neurology disorder. This is the risk factor for a sleeping problem, and then we're going to talk about it. First of all, I will add something to medical comorbidity. Is actually a lot of us not sleeping well, and then we're going to talk about it because of the medical problems that we have, like hypertension, we're going to talk about it like a GI problem, and then this is going to be our talk. First of all, why the women has a problem? Unfortunately, this is true. The women has more problem in the brain is basically adjusting to sleep. They're talking about hormonal basically environment during the basically various phase of the basically women life. 40% is happen around the basically menopause period and actually post-menopause period. That's the worst time of the life of the women that have a sleeping problem. Hot flashes, depression, anxiety, sleep disorder is basically caused restless leg syndrome, sleep apnea. A lot of them is actually happening in the women after the menopause. And this is probably related to the hormonal things in the women that they have more problem. One of the major problems that we see is a cardiovascular disease. This is actually both sides. Sleep has, it's a big relationship between sleep and cardiovascular disease. They think when we don't sleep, we have a lot of risk to get the heart disease. Because again, the things that we talk about physiology of sleep. On the other side, they actually think about if we have heart disease, we're not able to sleep. Because imagine the heart is a major basically pump of our body to basically sending the blood to the brain, having the brain perfusion. And if there is a problem with the heart, then our brain not getting enough circulation and the blood. And that's why a lot of people, even with the heart disease, they have a problem with the heart. There was a study was done in Japanese worker. They see that the Japanese worker that sleep less than 5 hours, they have actually 3-fold increased risk of heart attack. And that's something is very important. And again, that's relationship between that. But a lot of the study shows that people have coronary artery disease, like they have a heart attack, or they have basically blockage in the coronary artery. They have more complaint of disturbed sleep in the people they don't have a heart disease. And that's a very interesting thing. A sleep disorder have basically the breathing, like a sleep apnea, also shows to increase the risk of cardiovascular disease and a stroke. And that's what's very important. We're going to talk about it, why we always tell the people if you have a sleep apnea, you need to be treated, because again, there is a big relationship between a sleep apnea and increased risk of cardiovascular problems and also basically a stroke. The potential mechanisms, they talk about hypertension. Again, the things that happen with hypertension, we have some chemoreceptor sensitivity that is basically going to be active. And again, it's the thing that happen is we're going to have more sympathetic basically pathway going to be active if we have more cardiovascular disease. And that's probably one of the reasons that we have this issue. But remember that a lot of us, we take the blood pressure medication as well. And fluctuation in blood pressure also can have effect on sleeping. A lot of us, when we take the blood pressure, a lot of the blood pressure medication, the steady state of the medication goes to the blood and actually be active. It's going to be happen at nighttime. That means at nighttime, your blood pressure suddenly drop, and that's the one. Sometimes is one of the reasons the brain not getting enough blood, and suddenly is going to wake up. And that's one of the things is very important when you basically take the blood pressure medication. It's the fluctuation of the blood pressure is actually very important. But again, always cardiovascular disease comes with a sleeping problem. Congestive heart failure, it's one of the other things. It's sleep complaints, again, difficulty falling asleep. They have frequent, basically nocturnal. I mean, a lot of the people, they have congestive heart failure. They have a problem with urination because they have swelling leg. And basically, the body is very puffy because of congestive heart failure. You go and basically lying flat in the bed, and the first thing is going to happen, this edema that we call swelling feet is starting to moving toward your kidney, and then you're feeling that you have to go to the bathroom. And that's why multiple time urination comes with congestive heart failure. Beside of that, they see that a lot of people with the severe congestive heart failure, when they're lying flat, what's going to happen? They get shortness of breath. That's why a lot of people with congestive heart failure, you see they put a lot of pillows. And that's one of the other reasons that the people actually get dyspnea or shortness of breath during the sleep time. And this is coming. Diabetes. Again, diabetes comes with a sleep problem. Again, when we compare non-diabetic with diabetic people, we see that the higher rate of insomnia and excessive daytime sleepiness, 75% of population report poor sleep quality if they have diabetes. And again, one of the reasons is fluctuation of the sugar. Again, this is very important because we give you medication, you take the medication for diabetes, and the blood sugar, it's kind of like sometimes after 3 or 4 hours goes down, up, down, up. Imagine that this blood sugars actually go down toward the night. The brain not getting enough sugar, the food of the brain is sugar. And that's why a lot of diabetic people, because of fluctuation of basically the sugar, they have a problem with the sleep. And a lot of people, they're taking insulin. The peak of insulin is going to happen at nighttime. That's one of the scary part actually in our practice. And that's why this fluctuation in the sugar make them to be awake in the middle of night. They have a nightmare. The heart rate is going to increase, and that's one of the other reasons. Diabetic people, they have a neuropathy pain. They're always feeling the leg pain and all the things. And that's one of the other reasons they have a lot of a sleep problem. And again, they can have restless leg syndrome, but we're going to talk about it. Respiratory problems, the people have a sleep apnea. They can have COPD, which is we call chronic obstructive pulmonary disease, or chronic bronchitis or emphysema. The people who are smoking for a long time, they could have this problem. And again, there is a big relationship between obstructive sleep apnea and also the COPD in people. And again, when we have COPD or chronic we have the problem with enough oxygenation. Again, we have decreasing total of sleep time. We don't have a good high quality sleep, especially in the people when they have COPD or chronic emphysema or chronic bronchitis. And a lot of the study shows that people that have asthma, they're feeling very restless when they're in a sleeping time. And in the people that they don't have it. And again, the sleep can be disturbed by asthma attack. A lot of the asthma attack happens at the midnight time. And again, this has happened mostly in the second half of the night and with respiratory. GI problem, this is very interesting. The gastritis and peptic ulcer, they see there is a big relationship between the GI problem, like stomach problems, heartburn, acid reflux, and a sleeping problem. Again, one of the things they found is that the people they have GI problem may have, there's association between a sleep apnea and also GI problem. And this is very interesting things that they talk about it. But again, one of the very interesting things that we found is circadian cycle has effect on the secretion of acid in the stomach. And again, this is actually very important because you can see here increase in basal acid output in the late evening hours and reduction actually in the morning hours. And the people that they have acid reflux problem, and this is the something together, we see when they are basically in the supine position because they have to lie flat, we see that they have a delayed in acid basically clearance by esophagus. And this is kind of like a things that happen, they have a lot of acid reflux at night. And that's one of the reasons when you go to the doctor and you have acid reflux, they're always telling you, make sure you elevate your bed because it's going to be hard for your stomach to basically get rid of the high level of the acid and go back again to the stomach. But a lot of the study shows that just irritation of acid, because we always feel discomfort, we really don't know what's the reason that we wake up. But that shows that one of the reasons that people feel irritation on the esophagus and they wake up. But really they don't know what's the reason that actually they wake up. There is a big relationship between inflammatory bowel syndrome. The people have IBS. They feel that most of the symptoms happen at nighttime. They feel bloated. They feel kind of like, again, uncomfortable in the intestine. And we can see in ourselves. Imagine that you have a bad dinner and that you don't like the dinner, or it's very fatty, or something that you don't like it. And you actually says, I couldn't sleep last night because I had a very bad food last night. And what's the reason? Because your intestine is moving a lot. And when your intestine is moving a lot, you have to turn in the bed, you can't sleep. And you promise yourself, tonight I'm going to have a light snack. I'm not going to eat anymore. And that's exactly the reason. Because when your intestine, we had actually the picture, or body movement supposed to be suppressed close to the midnight. And imagine that we eat something that we don't like it, or our intestine don't like it, and it start to moving our bowel movement. And that's one of the reasons we're going to wake up. We're doing something against the physiology and against the cycle. And that's one of the other things. Chronic pain, and the people have fibromyalgia. There is a big, we talk about reticular system. We saw there is a place in the brain working as a cardiovascular and pain, and also working with the pain. And this is two important thing. And the people, they have a pain, they're not able to sleep very well. One of the reasons is because also the pain receptors goes to the reticular system in the brain, and at the same time, they're going to wake up. Because there's the reticular system going to be active, but we talk about the theory that the reticular system is supposed to be tired and goes to sleep. That's the way that we can go to sleep. And again, we see that the people, they have pain, they have basically reduced the amount of a slow wave, the REM sleep, and again, that's one of the reasons. And we see a lot of things with the people, they have arthritis, like knee arthritis, ankle arthritis, hand arthritis. The very, very mild pain can be the reason that is going to disturb our sleep, because that's the way it is. I mean, we really don't know. We think about, oh, I can't sleep. And you actually see that, okay, like 2 weeks, I'm not able to sleep. 2 months, 3 months, not 4 months. You go and take more sleeping medication. But the problem is not a sleeping medication. Problem is arthritis. Because imagine in the REM sleep, we talk about it, that your body start to move. Your knees start to move, okay? But you have arthritis in your joint, means your knee start to hurt. And that's one of the reasons you feel pain and your brain's going to wake up. And that's one of the reasons that people have basically the chronic pain and the sleep has a big issue. And this is very challenging. This is very challenging also for physician, because a lot of this pain medication we give it to you. You come out asking me, okay, I have knee arthritis. I will go, okay, well, I can't do anything for you. I mean, you're not candidate for, even if you do the replacement, you're still going to be in pain. I give you some narcotic. Narcotic makes you to sleep during the day, and then your circadian rhythm that we talk about it is going to change, and you're not able to sleep at night. And that's one of the other problems. That this is a very big challenge for all of us. Again, aging by itself, very common. One of the reasons is 2/3 of the people that they go through the aging, they have one of the things that we talk about, cardiovascular disease. How many people in this room take blood pressure for hypertension? I'm sure a lot. And that's cardiovascular disease is coming. Again, a lot of us, we're taking medication for acid reflux. I mean, acid reflux is one of the other things. Again, irritation in our bowel. I mean, we have a lot of times our intestine is actually going to be active. We talk about respiratory problem. We talk about a lot of things that actually can impair on that. 40% of, by aging, they have a problem falling to sleep. 30% nighttime awakening for many reasons. Again, we talk about it. Fluctuation, blood pressure, change in the circadian rhythm, change in the brain. 20% complain of early morning awakening. 20% daytime sleepiness. And half of the basically community rolling older adult use at least over-the-counter or prescribed medication for sleep. And that's a lot because we have this issue. Again, we have decrease in quality of sleep. We have basically decreased total of sleep by aging. We see the basically latency of sleep is going to be increased. The time we go to the basically to fall to sleep. We see the daytime napping is actually increased. Earlier bedtime, earlier morning. What is going to tell me? Or circadian, 24 hours we talk about, remember the cycle, that's one is going to be changed. And we're going to have a more wakefulness at the nighttime. One of the things we see by aging is basically change in our life. Besides of chronic medical illness that we have the loss of a loved one, we have a reduced social contact. There's the change of the daily life. Imagine that you're working for like 40 years, 30 years, wake up early in the morning, goes to the work, and for 30, 40 years, that's the way your brain learned to go, wake up, and then go to bed at night. And now, today I'm coming, congratulations, you retired. And tomorrow morning, you'll see, okay, now I'm not supposed to wake up tomorrow at 6 o'clock in the morning. That's great. You can sleep, but your brain is not ready for it. Because your brain, you didn't say congratulations to your brain doesn't understand what does it mean with retirement. You actually retrain your brain for 40 years or 30 years to do this circadian rhythm. And now, suddenly, with all the other things, because the time you become retired, you have already hypertension, you already have the cardiovascular problems, and you say, okay, I have a backpack of the disease, and I have my retirement paper on the other side. Now, I have to deal with my sleeping problem. That's one of the reasons that people get actually sleeping problem. That's one of the reasons because it takes time. The circadian is going to change. And the other problem is just by aging, circadian rhythm is going to change by itself. And that's two things together make our sleeping worse. Again, depression, a lot of things, emotional things is actually going to impair our sleeping. If we go quickly on here, we see that basically if we can look at somebody that actually at the age, starting from 16 to 19, go all the way to the age of 80, we see how much is actually going to change. We see basically we have less deep sleep, less dark stage 3 and 4. We actually have more, I mean, you can see the REM sleep is actually going to be more. That's why in elderly people, or when we aging, our sleep's going to be very shallow, not very deep. I mean, we can easily wake up. And then you see the time is actually going to change. Again, older adults have increased light sleep, stage 1 and 2. But again, reduction in deep sleep is stage 3 and 4. And again, we see that for REM sleep, some decreasing, again, some basically increase. But one of the things we see more episode of the REM sleep, but the REM sleep is very, very short. And that's something that we can see to change in older adult. One of the things that we can see, again, the hypothalamus, we talk about suprachiasmatic, basically nucleus that we talk about circadian rhythm. There is some change at that center of the brain. The center, you remember I told you, get the light in from retina of the eye and then go there. They think that by aging, this center is actually going to change. And again, older adults are more sensitive to disturbance of circadian timing and more susceptible, basically, for jet lag and shift work disorder. I mean, when you're getting older, it's very hard to be a night nurse. It's very hard, or go to travel overseas because you get more jet lag. And again, a study shows the poor sleeping, basically sleepers takes more medication, make more physician visits, poor self-rating of their health, and this is true. Again, that's, again, sleep and the problem that we talk about. There are a lot of things is going on. I'm going to go quickly go down. Insomnia, we have breathing problem, we have restless leg syndrome or periodic limb movement, we have circadian rhythm sleep disorder, we have REM sleep behavior disorder, we talk about it briefly. We have changing sleep just for dementia. I mean, dementia has its own protocol. And again, we have other problem that is people in the hospital and nursing home that they can't sleep, and we're going to talk why. Again, insomnia, difficulty in falling, staying asleep, waking up too early, experiencing poor quality of sleep. I don't know if you saw the movie of Insomnia, Al Pacino, but that's very nice movie about a cop actually go to Alaska, and he was not able to change his circadian basically rhythm. Again, this is insomnia caused with daytime sleepiness, fatigue, and we actually has less concentrated. 30% when we are actually going to be 65 years older. And again, starting from middle age, from 40, 50, and then all the ways go up. Risk, again, female, we talk about it. They have psychiatry disorder. They have social isolation, low socioeconomic. They see that there's more risk. And the last one, or last week talk, polypharmacy. We talk about it. Taking too much medication. All this medication we're taking, they have some effect in our brain. They have some effect in our circadian rhythm because it's changed the fluctuation. A lot of medication, more backpack. You come to see, we're going to go see Dr. Ayati. My job is actually just increase your backpack more. I mean, every time you come to see me, I add another 2 to 3 medication to your list. And that's the way we practice. But again, you take more medication, and you see that there's more impairment of your sleep. That's also the risk. Depression, again, one of the major things with depression, we see the people actually wake up so early. They cannot go basically to sleep, and a lot of time they actually goes to the nighttime, they're actually going to be awake. Again, chronic insomnia by itself, it's a major risk for depression. And we know that already because there's sleeping problem. Anxiety is not only for patient, anxiety is also for caregiver. We see a lot of time, that's the problem. We have demented patient at home, and you have to take care of that. He or she is not able to sleep. You also are not able to basically sleep because this is the problem. 40% of older women who has family caregiver of adult with dementia, they actually, 40% of them, they actually see that taking some sleeping medication because they can. It's very hard. It's very challenging. Medical issues, we talk about it. Nocturia means waking up at night and go to the bathroom. This is the things is actually going to change. Multiple reason in men may be related to big prostate. That's one of the reasons actually we wake up more and then go. And a lot of women actually, they can have this problem, irritation because of the low basically hormones, something we call atrophic vaginitis because the vagina is very dry, and that's why one of the reasons they have to go more urgency to the bathroom. And that's one of the reasons that at nighttime it's happened. Medication that I'm giving to you, like for example, you come to me and say, you know what, I'm going to give you some water pills because you have high blood pressure or heart failure. You need it to take it. There's no question about it. But that's going to disturb your sleeping as well, especially if you take this medication toward the evening time. A stimulating agent, I give you, you drink some caffeine, I give you some bronchodilator. Especially bronchodilator is very important. The things that we use it like albuterol for asthma or chronic bronchitis. We see sometime in the hospital as well when we're giving the basic nebulizer to the patient, they're not able to sleep very well because they stimulate the brain. And again, a lot of the basically medication that we talk about it, nightmare inducer, that I talk about the basically dementia medication, antidepressant medication. That's very interesting because a lot of SSRI or SNRI medication, you name it SSRI, like a serotonin basically receptor inhibitor, Celexa, Effexor, you just name it, Paxil, Fluoxetine, and all of them, it's actually have effect on sleeping. It's not helping you to sleep. A lot of antidepressant medication actually cause more REM behavioral disorder, have more REM basically phase, and you're going to have more dreams when you have actually taking this medication. And alcohol is very interesting because when we drink alcohol, we feel a little bit drowsy first, but later actually shows, a lot of study shows later, you actually have a slow wave sleep. And then actually the people actually drinking alcohol, they actually said, you know, when I drink a glass of wine, I just fall asleep. It's true. There's no point. But it's very short acting. And then the other problem is alcohol that we talked last week about, that when we age, we're getting more fat. We have less muscles. It's true. We're all getting less muscles when we're aging, and we have more fat. Alcohol also, in order to clearance from the alcohol, we need enough water in our system to wash out the alcohol. The problem is when we're aging, the amount of the water in our body is going to be less. Means if like 2/3 of my body now is water, when I'm going toward the 60, it's going to be 50%. Means in order to get rid of the alcohol, toxic part of the alcohol, I have less water to get rid of it. And that's one of the reasons the toxic effect of alcohol is coming. And I have more fat, which is alcohol distributing so fast. And that's one of the other reasons actually I have very interrupted sleep when I drink alcohol. And that's something is related. Again, a sleep apnea, I don't want to go on detail, but the sleep apnea is obstructive, is central. And again, this is the very new things actually. In the last 20 years, there's a lot of discussion about sleep apnea. I'm sure that some of you basically go and see your doctor, says you have a sleep apnea, you need to use a CPAP machine or something. But you can see actually on this picture that what is happening with somebody who has obstructive sleep apnea. Look at the air. Air, this is the normal air rate, and this is somebody with obstructive sleep apnea. Has obstruction, air not going very well toward the lung. It's actually coming back. And that's why you don't get enough oxygenation at nighttime. And again, we talk about it. Don't get oxygen. Your brain is going to be suffering from the low oxygen. You're going to wake up. And that's one of the things with the sleep apnea. That's the sleep apnea is very important. Coming with the snoring, but some people, they even have a sleep apnea without a snoring. Alcohol, it's one of the other reasons it can increase the risk of that. There is a relationship with dementia. We see a lot of demented people, they actually goes toward the sleep apnea. Why? Question mark. We don't know. And again, a lot of people with the sleep apnea, they don't have any symptoms. One of the symptoms that you say, you know what, I sleep 8 hours a night. But you really don't know you have a sleep apnea. You actually see the effect of a sleep apnea the next day. You feel daytime sleepiness because you don't get enough oxygen last night. You basically, your brain suffer from the low oxygen, not able to, again, repair, not able to ready for the next day. And that's one of the reasons the people actually feel very sleepy during the day. And again, the headache, personality change, memory, confusion, irritation, all is related to the low oxygen. And this is coming with sleep apnea. The best person for snoring is your partner. Is always complaining, oh my God, you snore a lot. But that's something is going to be a trigger for you to go. CPAP machine, we use it. The problem with the CPAP machine, to be honest, is adherence. I mean, it's hard for a lot of people to actually use it. A lot of people, they hate it. I have a lot of patients, they love CPAP machine. I actually questioning myself, if I have a sleep apnea, can I use it or not? I really don't know, just be honest with you. But again, there is a true CPAP and BiPAP. There is a new devices is coming, is more comfortable. But again, if somebody has a sleep apnea, I'm saying very, very important thing. We talk about it. There is a big relationship between a sleep apnea and cardiovascular and a stroke. If somebody has a sleep apnea, has more risk to have high blood pressure, has more risk to get a stroke or heart attack. And that's very important because low oxygen, and low oxygen. Periodic limb movement, we talk about it, that we need to move our limbs, but a lot. It's basically kind of like a reason that people get disturbed, increased by aging. Why the reason is, we really don't know. We see a lot of people, electrolyte abnormality can cause that. Low sodium, low potassium can cause that. But that's one of the other things. One of the other things is very important is restless leg syndrome. That restless, they feeling always kind of like they need the urge to move off the legs at the nighttime. It's kind of like uncontrollable. Some of them, they don't have an urge to move. They're feeling the sensation that they have to rub and basically massage their leg. And that's kind of things that a lot of people at nighttime, they actually goes and massage their leg. They're feeling very uncomfortable. And again, the restless leg syndrome can happen also when we are actually not sleeping. Even during the day can happen. And the problem is in elderly has a very different expression. A lot of people say, I'm feeling very uncomfortable in bed. But that's why it's very important to actually get more history because a lot of people actually have restless leg syndrome. And again, it's very difficult in the people with dementia. In demented people, is very hard, but sometimes they're massaging. But a lot of time that I have this problem in nursing home, a lot of demented people, because they're not able to express themselves, they becomes at night agitated. They actually wake up. They're walking around the nursing home. The nurses call me and said, Dr. Ayati, do something. This patient is just walking around. And like 2 o'clock in the morning, I say, oh, okay, give our Ambien, give the medication. But this is not the reason. This is the poor patient has some restless leg syndrome. And that's one of, again, it's very, very challenging to diagnose. A lot of physicians actually, they miss this diagnosis. And this is, we actually had the last month, a case presentation that I had it with my students and residents at Stanford, that we had a case of restless leg syndrome that we're going to talk about why is actually happened, is induced by some of the medication that we are giving to the patient. And again, family history is one of the reasons. Women is actually more than the men. I'm sorry, but this is, again, this happened in them. Painful part, again, with demented patient. Some people that restless leg syndrome comes with iron. Again, iron deficiency, one of the reasons. Some of the medication, that's my point, some of the medication is actually increased the risk of that. One of them is caffeine or tea. Anything have caffeine or tea is actually, especially during the evening, can increase that. If you drink soda, I mean, especially the soda has a lot of caffeine, Mountain Dew, I mean, Pepsi, Cola, and antidepressant medication is actually can increase the restless leg syndrome. The case that actually we're talking, it was a guy that actually has restless leg syndrome, become depressed because not able to sleep, went to the doctor, and because of depression, we give antidepressant medication to the patient. We make it worse. The patient wake up in the middle of night, goes to the bathroom, boom, fall down, broke the leg, and then end up to the hospital. But the problem is, initially, was not depression. The problem is that this poor guy was not able to sleep, and we give antidepressant medication, make it worse. And that's very interesting thing. Benadryl, Reglan, Tylenol PM. A lot of people actually take the Tylenol PM. They think is actually help. In people with restless leg syndrome, is actually make it worse, because it's actually going to be more inducing of the movement of the limb. Again, circadian, we talk about it. Change in the 24 hours. I'm actually going to quickly go there. And in the people with dementia, change in the circadian, the place, the suprathalamic, basically nucleus, is actually happen to change the time of day, when the time is actually they need to wake up, when the time is actually they need to go to the bed. And again, one of the basic things is the light. I think you remember the last week we talked about a light and in people. One of the things we see in the nursing home people that we talk about light therapy, one of the major reasons that we're not able to sleep in a hospital and even in nursing home because we don't get light. I mean, this light is horrible. I mean, this fluorescence light is horrible. Imagine that you are in a nursing home or you are in a place and you don't get the light exposed. One of the things you see in the cities that they're more cloudy, or like in European actually country that they actually has more clouds and rain, they actually have a lot of problem with nighttime agitation and sleeping problem because we don't get enough light. And we talk about the melatonin release from the brain. That is very, very important. And that's one of the things. Hospital and nursing home, horrible place to basically sleep. And when I was on call in the hospital, I couldn't sleep because always is cold. And again, a lot of the basically, I get a lot of the phone calls, but even if I have like a half an hour, I couldn't. I always noise. It's the light. It's me because I order, you know what, every 2 hours wake you up and basically give you some medication. And again, one of the other things that during the daytime, the people actually, because there's nothing else, I mean, you have one IV here, something's attached to you in the bed, you don't do anything, you're going to go sleep during the day. That's why your circadian rhythm, remember, your circadian rhythm is going to change. And that's why when times is going toward the night, there's less nurse in the hospital, you're not able to sleep, you basically make irritation for the night nurse and say, oh my God, why you don't sleep? You need to sleep because I need to see another patient. And that's why the way they call us. And I say, oh, okay, give another sleep medication to the patient. That's very easy things. But again, again, a lot of the medication, psychotic medication, we give to the patient. Again, light is changing. ICU is a horrible place. I mean, imagine the noises and everything. I'll never forget the time when I was actually intern in ICU. After a month, when I finished my rotation, still the beeping of monitors was on my brain. I mean, imagine that you have to be 24 hours in ICU, beeping the monitor and everything. This is all disturbing your sleeping. Now, we talk about management of sleep. Now, we're going to briefly, we talk about physiology, we talk about what's happened, and now we're going to see what is the basically treatment for sleeping. We wanted to sleep. And the best thing for a sleeping problem is non-medication. We need to change a sleep hygiene, basically. And what we can do is sleep hygiene. One of the things we need to help ourselves to find what is our circadian rhythm. And that's very interesting. Because for me, my circadian rhythm is horrible because I have to wake up so early in the morning. I disrupted multiple times at night with my pager is always beeping. But if I really wanted to help myself, I have to find what is my circadian rhythm. I wake up 7 o'clock in the morning and then goes basically all the way to like 8 p.m., 10 p.m. And 10 p.m., this is the time for me to go to bed. I need to do it every day. I need to train my brain to understand this is my circadian rhythm. And everybody can find his or her own circadian rhythm. And always goes to the bedtime in the regular time. But this is very important because that's why I always have advice from your doctor. Wake up exactly every day at the time that you wake up, even on the weekend. If you don't do anything, if some of you are actually working in the weekend, wake up exactly. If you wake up every day at like 7 a.m., wake up exactly at 7 a.m. Never go to bed unless you are sleepy. And that's very important. If you don't feel sleepy, that's okay. Bed is not the place you go and think. If you want to think, there should be another room or any other place. But that's very important because a lot, and you know why is that? Because this is exactly the time when you go to bed, all the things is coming. You make a plan. And because you don't do any other thing. Like, for example, now you're doing computer, you're watching TV, your brain doesn't concentrate very well. But when you go to the bed, light is off, TV is off, and now you can, oh, you know what? I'm going to do this tomorrow. I need to call somebody tomorrow. And that's horrible. That's actually one of the reasons your brain, you ask your brain, invite your brain to be calm, but you're doing something on the other side that you ask your brain to be active. And don't take naps. Again, I'm saying that don't take naps if this is for somebody who has a sleeping problem. A lot of the study shows actually some short naps in the afternoon is actually very helpful for health. This is a big discussion. This is a new actual discussion is coming on. And they shows that actually the people takes like a 15 to 20 minutes nap in the afternoon. They're very healthier actually when they're getting older. But again, I don't think so in the lifestyle in the United States, anybody can get a naps in the early afternoon. But if you do it, it's good. A lot of European countries, actually, they do. But a lot of people that they have problem with the sleeping, we always recommend don't take any nap because this is going to be your total time is going to be less. Exercise daily, but not immediately before bed. And this is very important because if you be very active, you do a lot of metabolic things, and when you go to bed, you're not feeling tired. I mean, you're basically going to be very stimulated and active, and this is exactly like caffeine or anything that you're drinking at that time. Do not use bed for reading or watching TV. Bed is always the place for you to go to bed, and this is very important because this has happened now. We have TV in the room, we turn it on, we watch the TV till we feel tired, and then just basically turn it off. The study shows your brain needs to understand the location. If you have a TV room, just go to the TV room, watch your TV, finish it, and then come to the bed. When you come to the bed, bed is only place for you to basically sleep, not even reading the book. And that's very important. Relax mentally before going to sleep. Even don't use bedtime as a worry time. And that's something is challenging. But again, believe or not, it's much actually important. It's one of the best things that you can do to helping you to have a better sleep. And again, this is also working with that. If the hungry, and this is very important, if you're feeling hungry and you go to bed, you're not able to sleep because your brain needs glucose in order to basically, and then you have to actually go and get the lightest snack. But if you have reflux or you have acid problem, it's better to not actually eating any heavy things and before actually to go. I actually have a patient that actually was telling me that every morning before actually he goes to bed at 1 a.m., he has an ice cream, a hot dog, and everything. And he actually asked me for the medication for sleeping. And I said, I think we need to change your habit for eating an ice cream and hot dog at nighttime. And then he didn't like me actually with this my recommendation. But limit your caffeine, alcohol, and nicotine. But if you have to drink, if you have the habit of smoking, not before bedtime. Remember, we talk about dopamine. And all of them is actually cause a stimulation of dopamine, and you're not able to sleep. A lot of things that we see. Wind down before actually go to the bedtime and maintain routine period of preparation for bed, like washing up, go to the bathroom, everything. Just make a routine and prepare yourself to go to the bed. Control nighttime environment, temperature, darkness. Again, the same thing that we talked. That's why a lot of people not able to sleep in a nursing home and hospital, because it's uncomfortable, noise, and, I mean, doctors, nurses everywhere, and this is other things. And always try to familiar background noises. I have a hard time every time I go to travel, go to a hotel and have the basically air conditioned and has always noisy, and then it disturbs me. I mean, I can't sleep. I mean, you need always your brain a background noise to be stable, and it's hard. But again, that's something you need to think. What is the barrier in your home environment that is not allow you to sleep? And if unable to sleep after 30 minutes, this is very important. Get out of bed, and then go do something, listening to the music or reading, but not in your room. And if you wanted to read, never actually turn on all the lights on. It's actually very, very basically bright light, and actually is, but not very bright light, is actually kind of like a dim light, and just relax your brain. But after half an hour, if you don't sleep, just leave it. And again, behavioral therapy shows is actually very, very important, better than basically any other thing. There is a stimulus thing control that we use. The goal is basically change the behavior. The patient actually instruct to go to the bed with only sleepy, not to go to bed to watch the TV or eat. Again, get out of bed if you're not sleepy. Don't take nap during the day. Another, there is sleep restriction. Basically, goal is improve the sleep efficiency. One of the things that we recommend, write up whatever you're doing. I mean, have like basically daily things that actually write whatever is doing. And again, that's a way you can actually calculate yourself that, for example, I need to increase 15 minutes more in my bed, and then goes and check with the doctor that is very patient, listening to you, and then basically check. And this is actually shows that gradually increase the time in bed, and that actually shows a lot of improvement. And all of them, there is a study behind them. They've done a lot of study, and they found it actually is very, very effective on the people. Again, cognitive basic intervention, educate the patient to change them, including normal change in sleep, increasing with age, change or pathologic. Again, if you have any other medical problems, goes and talk about the medication. We can limit at the evening time. Relaxation technique is actually very, very important. Is a lot of people actually been, and this is the thinking about and thought about the tense and relax each muscle group. They've done a lot of study. They actually done electromyography, which is connected to the muscle, and the patient's giving feedback that if they are still tense. Because a lot of time when we go to bed, we are tense. We are basically not relaxed. And that's the things that you can actually learn. Bright light therapy, this is very important thing. That's the things that we talk about it. It's actually help with the people first that they have seasonal depression. Because some people, they have depression when it goes toward the fall and winter because light is less, and they becomes more depressed. And they actually found that they do a lot of the basically light therapy, and this is kind of like a box that they do. Japanese people and Australian, they do a lot of this study. They love light. And this is true because we can see, I mean, the things that we talk about here, that imagine that you're going to be in the room and not going out. And this is something that has always happened. Your circadian rhythm is actually going to change. And there is a lot of study they've done. Basically, 8 healthy women at the age of 67, they have 1 hour of morning light therapy each day for 1 week, basically followed by cross-cover to non-light therapy. For 1 week, a sleep parameter were basically recorded. They have something on the wrist that actually record what's going on. By the treatment day 2, they found that the self-reported motivation, happiness, alertness, mood, refreshment, and appetite were significantly improved after they've done the light therapy. And as how much is light is important, we talk about physiology. Understanding the physiology, we can understand how light is very important. A lot of us, we travel overseas. And this is the trick that I use every time when I travel overseas. Actually, because my time is changed, I go in the middle of day outside for 15 or 30 minutes. I try to get the sun exposed to my brain. And that's the things that I know that now my clock is going to change. My clock needs to be changed. And that's the way exactly with the light therapy. And again, by the day 4, the sleep maintenance, the anxiety, and actually the sleep filling was much more improved. And it was a very interesting study actually they've done. And again, there's a lot of other study was done. 36 basically patients, they have Alzheimer's, and they have a problem with the sleeping. What they've done, they actually, the patient and caregiver, they educated, and they actually tried to basically do the light therapy for 2 months. After 2 months, the treatment group shows significant reduction in the number of the nighttime awakening, total time at nighttime, and depression in compared to control group. It's a lot of it. And after the 6 months, the sleep parameters benefits were maintained. Additional significant improvement in duration of night awakening was 6. I mean, that's how much is the light is very important. And again, after controlling for severity of cognitive impairment, the treatment group had less daytime sleepiness in comparison to the control group. The people that they done light therapy in comparison, they're all Alzheimer's and demented patients. And they've done this test. And it was very actually interesting. It was published in 2005 in Journal of American Geriatric Medicine. If we use the medication, always remember, medication is only for temporary. It's not chronic treatment. The best treatment for sleeping, again, change the circadian rhythm, understand your brain. What is my brain clock? Where is my brain clock? And how can I change with basically pharmacotherapy and taking medication? If we use the short-acting medication, like, for example, Xanax or Ambien or any other kind of medication, they are working for falling to sleep. If I use the intermediate, basically, medication for people staying asleep, and chronic use, again, increase mortality, morbidity, and one of the major problems is a long-term. Again, benzodiazepine is very famous one, temazepam, lorazepam, florazepam, long-acting, short-acting, intermediate-acting, but they bind to the GABA receptor in the brain. Then one of the major drug reaction that we talked last week about that is basically alter mental status. They cause rebound insomnia. Chronic use of this medication actually cause more sleeping problem because they change the architecture of basically your sleep. They cause confusion. They cause withdrawal symptoms. And this is very basically important. We talked last week that don't use long-acting sleep medication because by aging, we have more fat. When we have more fat, this medication is lipophilic. They like fat. They have more volume of distribution in our body because we have more fat. That's the reason if I take Valium 5 milligram at age of 40, I feel sleepy for 6 hours. But when I turn to 60 or 70, if I take the same 5 milligram of Valium, I feel totally drowsy and sleepy for 24 hours. What has been changed? Same medication, same company, same brand, my body is changed. I have more fat. And that's one of the things that we always saying about the medication, and we talked last week about that. Again, short-acting is better, but again, the chance of thing. There is a new medication, non-benzodiazepine, which is Ambien, Sonata, Lunesta. They are actually not like benzodiazepine, but they go to the same receptor in the basically GABA receptor, and they're actually working for basically sleep. They shorter duration, but there is a less risk for daytime carryover. But again, there is still risk of confusion, fall, fracture with chronic use. And we really don't know. But still, that's the only option that we have now. And we have melatonin that we talk about it. This is kind of like a good medication. But again, the same thing that we talk about it is generally prescribed for the people that they have difficulty falling asleep. Melatonin is actually binds to the 3 receptor. We have Ramelton is actually on the market now, and the melatonin is also, if you go to any food store or any over-the-counter, you see actually the box of melatonin. It's work, but especially in a circadian rhythm disorder, if you have like a jet lag, if you're basically traveling eastward, and in some people actually shows that in the chronic use is actually work. There is antidepressant medication that we use for sleepiness. It's true. Trazodone and Remeron and mirtazapine, you hear a lot of time. In the low dose, they have antihistamine side effect, and you can actually use this medication for sleepiness. Again, the major problem, remember, trazodone can cause some sort of the heart arrhythmia. They can drop your blood pressure, risk of fall. Remeron, mirtazapine, weight gain, and also, again, some people actually increasing the appetite as well. But again, one of the major problems is the next day is the sleepiness. Over-the-counter medication has anything has the antihistamine. There's like a Tylenol PM, diphenhydramine, herbal medication, melatonin is actually used. One of the major things, just remember, we had it last week, over-the-counter medication is very challenging because one of the things is actually an older patient, we have, one of the problem is adverse drug reaction. We really don't know what's the problem. One of the things is a lot of the over-the-counter medication, we really don't know what's going on because most of them is actually, they're not approved by FDA. They're actually there. And we have a lot of over-the-counter medication now. We really don't know what is the brand because every time we see, every time when I actually walk to the pharmacy, like in Long or Walgreens, I'm amazed at how much medication is actually. I actually stop every time and learn something because I really don't know. And imagine that you come to me and ask me that I take this over-the-counter medication. I have no knowledge. And what should I say? Should I lie to you? And I say, okay, I really don't know. But I'm telling you the truth. Over-the-counter medication, we really don't know. A lot of side effect is basically, that's the things that we discussed last week. Different packaging. Again, we really don't know what's going on. And again, lack of knowledge for people that they sell, patient, physician. And again, one of the problem is actually you take this medication, you have a side effect. I'm not aware of the side effect. You feel sleepy. You're coming next day and ask me, what should I do with my sleepiness now? And I say, okay, let me give you some medication to stimulate you during the day. I give you another medication, and you become super stimulated. Your blood pressure is go up. And I say, okay, let me give you some blood pressure medication. You started with the first medication, and I increase it to 3 or 4. And that's we call prescription cascade. And that we talked last week about it. Herbal medication, again, the same problem. A lot of them is actually herbal medication. They go with the same enzyme in the liver. We talked last week about that. And again, they actually cause a lot of the adverse drug reaction. And again, the physician, like me, I don't have any knowledge about the herbal medication as well. That's something. Valerian is one of the ones in the market. There is sedation, headache, withdrawal syndrome is that. And again, there has a big interaction with the CYP enzyme, which a lot of medication we take, it actually has either induce or inhibit the CYP enzyme. And that's why a lot of interaction with all of the medication. And just remember, herbal medication and natural medication, it really doesn't mean that they are safe. It really doesn't mean they are safe because, again, the chemical medication also coming from the nature. But we really don't know. The only problem is they may be a good medication. I don't know. But we really don't know what's going to be the drug interaction and other things. Wrap it up. Understand, first of all, what caused your sleeping problem, circadian rhythm change. Always go with a non-pharm medication. Again, use only medication if you really come to me or any doctor for transient time till you find your circadian time. And again, choose the physician to listen to you and have a plan to you. Definitely not me, because I was always, that's the problem. We always have a limited time. We really don't know what's going on with sleep. I always have this example. If I have a depressed, if I have an insomnia patient, in the other room I have a high blood pressure patient, if they give me the choice, which one do you want to choose to go and treat? I definitely not go with the sleeping and depression because it's very challenging. I will go with hypertension because it's easy for me. I give some medication. Your number is going to be better next time. You say, wow, Dr. Ayati is a good doctor. And I say, wow, that's good. But if sleeping things, it's very challenging. And again, relaxation, relax is very, very important. The way for future, understanding our brain, understanding ourselves, what's going to happen to our brain. And again, a lot of challenges is coming with aging and sleeping. We just need to understand ourselves. We just need to write about ourselves. What is our physiology? What is our body? What is my body change? What's the problem in my environment actually causing that? And that's something that is basically coming on. And again, I should say thank you to Stanford Health Library to actually making these things together. If there's any question is coming up, feel free to email me. I usually like email, responding to email once a year, but you can email me. But if there's any question is coming. But thank you so much, and I'm ready for answering questions. Thank you. It was a long discussion. We had also some delay initially, but thank you. Yes, please. Anybody wants to leave, because this is very late, and please.
The benefits and how to use dry light therapy, and also where can you buy the equipment to utilize?
there is a lot of the basically researcher. You mean you need information about that?
Well, I wanted to know how to use it also. I think
There is two things that they use. Some people actually they use it as like a box. There's kind of like a light box. They actually goes for hours in there, and they don't use any UV light in it because the effect of the UV light is going to happen to increasing the cancer. But they actually goes to the box and they get exposed better to basically to the light for the certain period of the time. And that's the way they actually train them, like for example, after 1 day, 2 day, and third day, and also the following week, how your melatonin secretion is going to change. And that's the way that actually they help with the sleeping situation. I mean, unfortunately, we don't do too much here.
we do it ourselves. Can we buy it?
You can actually buy, yeah, you can buy. I mean, I remember that actually I saw actually a nurse practitioner when I was actually doing my fellowship that she did with like some sort of like a study lamp and actually a blanket. She actually made some kind of like a box for herself. And she actually saying that this worked great for me. I actually goes and just reading something and have them more exposed to the light every day, like 3 to 4 hours. And it was very amazing. But again, we really don't need in California because we have a natural, basically light is actually going outside. And that's one of the things that if we expose every day ourselves, or body or brain, to get more exposed to the light, then actually we can train our brain to understand what's going on with circadian rhythm. But there is a way they do. In Japan they do, in Australia they do, in Europe they do a lot of this kind of like a light therapy as well. And that's also very interesting things that we last week we talked about experience of the people actually in Spain. There was also the other things that actually they've done a study that like in Barcelona, the way that actually they design the nursing homes is like they take the people from nursing homes to the streets, that a lot of the tourists and all the people actually they are there. And actually they found it is very effective because in the morning, instead of keeping them in the room, there's a lot of the volunteer, like the students, the Spanish volunteer people, they actually goes take the wheelchair and take the people actually to the street. And they get the light, they get the people around, somebody playing music, and they see actually they use less antipsychotic medication for them and also less sleeping medication. 2 reasons. They are less depressed, they're less isolated, and they're getting good exposed to the light. And they're treating 3 things for just putting people in the street. And it's very interesting because it's not designed like United States that you have to have a car. There's no place like a pedestrian or something you actually can go, and like a sidewalk you actually can go and sit. But there is the street is very small and the people can go around them. They found they're less depressed, more light, they've been sleeping better, and they're very socially active. And it's true. And one of the big issues that we have and always discuss with the nursing homes that I go and visit, and a lot of the activity we're providing for people in nursing homes is actually, again, inside. We do playing music inside. We do things, everything, even independent living facility and everything. We have this lecture inside. I mean, we're always in the room. But this is so sad because we have a Bay Area, great weather, but it needs to basically be active more in outside. And that's probably going to be helpful for them. Yes, please.
Do you recommend at least 7 to 8 hours sleep for every day?
That's a very tricky question because nobody knows how many hours you need for sleep. That's still a mystery. Some people actually can take like 3 or 4 hours of sleep and their body is actually functioning very well. Some people, they need 6, but again, the average time of sleep, they say 6 to 8 hours for everybody. That's a routine thing. But again, some people can functioning for like 5 hours or 6 hours, including me. But again, that's something that a lot of people, it really depends. I don't know. It really depends on your circadian rhythm of your brain, how many hours you need for sleep. Yes, sir.
You were going to say that as you age, the amount of melatonin that's produced by your body decreases. Mm-hmm. You didn't give any data about that. So is there any substantial reason or rationale for a supplement that some people might need in order to have an adequate amount?
Yes, it's true. I mean, but again, one of the things that we really don't know, we really don't know how much is actually decreased person by person. It's not like an average things that, for example, we see by aging, the melatonin production is going to be less because some people still can producing the same amount of melatonin without any problem. But we definitely see by aging, some people have less production of melatonin because, again, the change. One of the things they actually says that they don't. One of the other thing is they see it's not the amount of melatonin coming from basically suprachiasmatic, basically nucleus. The problem is the light is not getting there very well because, again, they have a cataract, they have a lot of the eye problem. They don't get enough light goes inside. I mean, somebody probably has insomnia in the fall, but yeah, that's. But again, unfortunately, we can't say that. We can't say, like, for example, checking the marker in the blood and say, like, your melatonin is normal, but her melatonin is not. We can't. But the people do experimental. Like, for example, you can take melatonin if you have a sleeping problem and see if it's going to affect on your circadian rhythm or not.
We take it at 2 o'clock in the morning.
You take it at 2 o'clock in the morning?
Is that what you would say? Because that's when.
No, I mean, but don't forget, in order to you take the medication, this is our last week talk, you need time for absorption, metabolism, distribution goes to your brain. You need to take time. That's why you need to take probably in the evening time to actually goes to the peak because you don't have the normal one from the brain. You wanted to have the taking something, goes to a small intestine, goes to the liver, and then from liver goes to your basically your brain. Yes, please.
What is the best time to take high blood pressure medicine? What is the best time of the day to take it?
I always say especially when we are getting older, the best time is actually going to be morning, early morning. It's very interesting because it was the Journal of Hypertension actually had an article like a year ago. They were actually talking about the monitoring the blood pressure at night, and they see that the people actually have dropping the blood pressure at overnight. They actually has a more side effect and complication related to dropping the blood pressure at nighttime. That's why the best time for blood pressure medication is actually morning. You remember the circadian rhythm that we talked about, the sharp raise of the blood pressure in the morning, and then all the way goes toward the evening, you have basically the highest number one. If you take sometime in the morning, early afternoon is the best time. For diuretic pills, I always say later afternoon, don't take any water pill. Because again, the problem is you just have to go to the bathroom multiple times. You need to give the time to medication, goes to your stomach, intestine, absorb. This is journey of the basically medication. This is a trip of medication. And then like 6 or 7 hours, you see the peak effect of the diuretic right away at like 1 o'clock in the morning. And you're lying in bed, you have to go to basically the bathroom multiple times. You basically make your sleeping worse with just this condition. Yes, please.
Continue her question, would you take it with or without food?
The sleeping medication? The sleeping medication. It really
No, blood pressure medication.
The blood pressure medication, it really doesn't matter. The only things is, again, some medication are again, some medication because of the lipophilic effect or some medication absorbing better with the food, then you take it. But to be honest with you, really, it really doesn't matter for blood pressure. Most of the blood pressure medication.
And if you have coffee with it too, or that's not a problem?
Coffee is raising the blood pressure. That's very interesting because the coffee is actually the same mechanism we talk about. The coffee, amphetamine, Ritalin, they are stimulated. They're raising the blood pressure. It's good or bad. It's good in some people. They have something phenomenon that we call orthostatic hypotension. Means a lot of people, this is the different topic that we're probably going to talk one day. When we age, there is a physiology in our brain is actually, in our nervous system is going to change. In order to, for example, I'm asking him, for example, to standing up right now. Or I'm standing up right now. If you compare the blood now is going to your leg and compare of the blood now is going to my leg is actually needs a lot of blood now because I need to contract my muscle in order to standing for like 1 or 2 hours to have a talk for you. Now, you wanted to standing up now, or he wants to standing up now. Then that means a lot of blood needs to go to the leg. Contract the muscles, he is able to standing up, okay? if this is going to happen, his brain suddenly going to be drop of the blood because all the blood goes to his leg, okay? And he feel lightheaded and dizzy. There is a mechanism and receptor we call baroreceptors in your brain, or a lot of the places like a carotid artery, that is helping us. The same amount of the blood goes to the leg. At the same time, same amount of blood goes to the brain. That's why when he's standing up, he doesn't feel lightheaded and dizzy. But by aging, unfortunately, 40% of people, they're losing some degree of this mechanism. And that's one of the reasons when we actually getting up so quickly, we feel lightheaded and dizzy. The other things, a lot of blood pressure medication that we are taking is actually the effect of blood pressure is exactly on this receptor. And they impair this receptor. That's why a lot of the blood pressure medication cause dropping blood pressure when you're standing up. And that's one of the reasons a lot of time I tell my patient, if I give you this medication, if you want it to standing up, please don't stand up so quickly. If you see something drop on the floor, forget about it. If it's half an hour to 1 hour after you're taking your blood pressure medication, forget about it. Let it drop on the floor. Don't go and drop, because if you go down, you feel lightheaded and dizzy. And and coffee, and now this back to question, coffee is good for some people. They have this effect. And actually, it's very interesting because I remember I had a patient who has orthostatic hypotension because of Parkinson's disease. And actually, Parkinson make it worse. And he actually was taking blood pressure medication for many years. But unfortunately, he's ended up with orthostatic hypotension. And I was telling him by joke that, you know what? Now when you're living here, go to McDonald's, take the fries and soda and coffee. You're free now to eat whatever is actually makes your blood pressure is going to be elevated. And have it the chips every night on your bedside. And actually, the daughter did it. Is actually always have like open chips for him at the bedside. And then every time when you're getting off the bed, having a couple chips or having a little bit of salt before you're getting up, because you don't have this physiology to maintain your blood pressures be elevated. You need something to help you. And you can actually take the picture of McDonald's and just put an advertise that this all medication is good for, this all food is good for you actually. But yeah, but again, that's the physiology. A lot of blood pressure medication has this effect. Coffee raises the blood pressure. It's good for some people to actually raise their blood pressure.
Is tea as bad as coffee?
That's a good question. It's a really good question because I'm trying to convincing myself that tea is better than coffee. I'm addicted to it. It's really, we really don't know. It shows that some kind of herbal tea, especially green tea, is very, very healthy. The things that happen is actually in Japanese people, a lot of the Asian people, they see that they drink green tea is actually help them for protection for cardiovascular activity, and it works. The only problem with the tea is tea and even the coffee is very diuretic. Means when you drink tea, I'm sure that you have this experience, you feeling that you have to go to the bathroom. And that's the problem in some people because you don't get enough hydration when you're doing that. You're either becomes dehydrated when you drink more green tea, especially green tea is very, very diuretic. And you actually go to the bathroom more and you becomes dry and dehydrated. The other problem is a lot of people drink tea at nighttime. And actually, tea is exactly like water pill. And you drink it like a later evening, and you have to go more to the bathroom. You're basically disturbing your sleep more by drinking tea. It's not make you to calm down. The time of the tea is very important. The same effect of the coffee. Coffee is also a very big effect like a diuretic. The other one is garlic. Garlic has very big effect on basically diuresis. That's why if you have a problem with the sleeping, garlic is good to make you to sleep, a little bit feeling drowsy. But again, it's a big diuretic. When you eat a lot of the garlic, you feel that you have to go more to the bathroom. And that's something you have to make a balance between what you're eating. But I don't have your answer. I really don't. It's really personal.
We got to wrap it up now because it's 5 o'clock.
Oh, great.
It's at 5 o'clock.
Yeah. Thank you so much. I appreciate it.